Okay, this is Chapter 17, Otorhinolaryngolic Surgery, starting on page 628 and 629. So on page 629, right where it says Introduction to Otorhinolaryngologic surgery, you need to write that is also known as ENT. So AKA ENT, and because it's such a long word, that's how I'm going to be referring to this chapter, is the ENT chapter. So the third line says the specialty involves treating diseases and trauma as well as plastic surgery procedures that often include microsurgery on very small structures. So we're in the ear, we're in the nose, and we're in sometimes the throat or in the back of the mouth. So under the ear procedures, under diagnostic procedures and tests, that second sentence, the tuning fork is used as a diagnostic tool to perform an initial assessment of a patient's level of hearing and may be used intraoperatively on a patient under local anesthesia to determine improvement in his or her condition. And they do not have a picture of the tuning fork, but I will show you what that looks like in class. Audiometry is a more sophisticated method of testing a patient's hearing. And then in the second column, the otoscope is a handheld lighted instrument used to view the external auditory canal. And you can see a picture of an otoscope at the bottom right in that figure 17.1. All right, next paragraph, the computed tomography or CT scans, also known as computed axial tomography or CAT scans, and magnetic resonant imaging or MRI are two specialized non-invasive methods of viewing the inside of the body. CT scans are very accurate in defining bony structures. MRI more accurately defines the soft tissues. A tympanogram measures the vibrations of the eardrum by placing a probe against the tympanic membrane. And then the electronystagmography, electronystagmography, ENG, is an exam that tests the balance mechanism in the inner ear. Okay, so on page 630 under the routine instruments, the fifth bullet, you'll see the Rosen needle. Anytime you see the word Rosen, you need to think of ENT because there are many different things associated with this name. There's a Rosen knife, a Rosen needle, a Rosen pick, and a Rosen suction because it's a very common name. And if I were you, I would write those next to Rosen needle, that there's a Rosen knife, needle, pick, and suction. 4 different kinds of Rosens. Okay, third from the bottom, there's Fraser, Barron, Rosen, and House suction tips, so multiple suction tips. And then at the very bottom, it says Fraser and Barron suction tips in various sizes. Okay, and so you can see that on the next page, letter G, there's the Fraser, and then H is the Barron suction tip. So make sure that you know those two different sections and what they look like. The H you would think is a Fraser, but that oval part where you can put your finger on that creates more section, that's actually the Barron suction tip as opposed to your Fraser. Okay, in the upper right-hand column, there's your myringotomy knife, and I don't think they have a picture of this, but I will show you a myringotomy knife. If you've been in the ENT room, you have seen this. It has a black handle. Okay, And then third from that list on the right, there's the micro instrument wipes, and that's what you use to clean the micro ear instruments. And you need to write that next to that, that the micro instrument wipes cleans the micro ear instruments. And so on page 631, you also need to know letter B. There's the farrier ear specula. That's what it looks like, but that's the actual name, letter B. And then I, the house alligator ear forceps. So B, G, H, and I are very common in the ENT room, especially when you're doing tubes, like you're putting ear tubes in. These are the four instruments that you're going to be using a lot, along with a rosin. Okay, on 632, before we get into our first procedure, in the second column it talks about dressings. So the ear dressing could be a very simple dressing, such as a cotton ball inserted into that external ear canal, or quite complex, such as a mastoid, like a Shea, or a modification thereof dressing. A mastoid dressing consists of antibiotic ointment, a non-adherent pad, fluffed gauze, and gauze that are wrapped around the patient's entire head. Okay, so our first procedure is the myringotomy at the bottom of 632, and we'll just have to know all of our anatomy. So the first is the tympanic membrane, is the separation between the outer and middle ear. It consists of three layers: outer epithelial layer, fibrous connective tissue middle layer, and the mucous membrane inner layer. A branch of the facial nerve that carries taste impulses from the tongue passes along the inner surface of the membrane. The tympanic membrane can easily rupture. The perforation can be caused by either external trauma or excess pressure from within the middle ear. It is concave, disc-shaped, pearly gray in color, translucent, and with a shiny appearance. The fibrous ring surrounding the tympanic membrane is the annulus. Next page, second bullet. Otitis media is a very common acute inflammation of the middle ear, usually caused by blockage of the eustachian tube, causing an accumulation of fluid that normally drains into the nasopharynx. The primary symptom of otitis media is severe ear pain. The main sign observed through the otoscope is an inflamed tympanic membrane. And you can see this, a lot of parents will have an otoscope at home to see if their kids have ear infections, and all you really do is on the pinna, the external ear, at the top you're going to pull up, and then you stick in that otoscope into that external auditory canal, and if you see a lot of red inflamed tissue, then you know that your child has an ear infection, or anybody. Okay, last bullet. The infection may require a myringotomy to remove the accumulated fluid and insertion of a pressure equalizing, or PE, tube to allow for additional drainage and to maintain the pressure equalization. Okay, so PE can have two, like when you see PE on the board, it can mean two things. Normally, it'll say bill pets, which means bilateral, PET, which is pressure equalizing tubes. Okay, and that's very common for kids. But if you also see PE, sometimes that means primary eustachian. And make sure that you know that PE can also mean primary eustachian. Under the equipment, there's the second bullet, those PE tubes of various sizes, and the disposable myringotomy knife. And so you can see the different types of tympanoplasty tubes. The most common one is that pink one at the top, and the white one. Those are just your standard tubes. That one in the middle is called a T tube, and when you put those in, you would pass a pair of scissors so the surgeon can trim. We also have razorback tubes. I don't know if any of these represent a razorback. I've never seen one before. All right, under practical considerations, the second bullet, myringotomy is not a sterile procedure, but best sterile techniques should be used. It's always worrisome when students go into the ENT room for the first time to do tubes or tonsils and adenoids because they're just putting on a sterile pair of gloves and then they're touching everything within the room. It's because it's just a clean case. If you notice, there is no prepping, really. So it's just something that you have to be done, that has to be done in the OR for anesthetic purposes. If not, they could have just done it in the office. Okay, under the surgical procedure, number 1, that second line is talking about any visible wax needs to be removed. And so wax is also known as cerumen. The medical terminology is cerumen. So make sure that you know that wax is cerumen, C-E-R-U-M-E-N. And so you'll remove that wax with a wax curette. And then number 4, under the procedural consideration, it says an instrument such as a pick, and I underlined that, such as a pick, and put rosin. So this is whenever you're going to manipulate that tube into that incision that the surgeon made, and they're going to manipulate it with the rosin. Make sure it's nice and seated into that eardrum. Okay. All right, and that allows the fluid to come out. It's like a little shunt that allows that fluid that's pressurized building up behind that tympanic membrane to come out, less alleviating an ear infection or future ear infections. All right, on 635, that takes us to tympanoplasty. The middle ear, which is the tympanic cavity, is an air-filled chamber located within the temporal bone. There are 2 openings in the wall of the middle ear, the tympanic antrum that opens into the mastoid sinus, and eustachian tube that connects the middle ear to the nasopharynx. The auditory ossicles are located in the middle ear, lateral to medial, so there's malleus, which is the hammer, incus, which is the anvil, and stapes, which is the stirrups. The ossicles are synovial joints. Further down, the short process of the malleus rests. Again, I want to keep wanting to say malleolar or malleolar. The malleus rests against the tympanic membrane, and the head articulates with the body of the incus. The incus is connected to the head of the stapes, and the footplate of the stapes rests against the oval window. Tympanoplasty is performed to treat a variety of conditions affecting the tympanic membrane and the ossicular chain. Okay, so continuing on to 636 under the anatomy, that last little sub-bullet, often the disease affecting the middle ear has extended into the mastoid sinus, which requires a combination procedure of tympanoplasty and mastoidectomy. Okay, so let's talk about the mastoidectomy on 638. The mastoid process is a projection from the mastoid portion of the temporal bone. Okay, on 639, first bullet, mastoiditis is a complication of acute otitis media. Second sub-bullet, infection that has not been cleared from the middle ear may be forced into the mastoid air cells through the antrum, causing destruction of the mastoid bone. Mastoiditis that extends beyond the mastoid sinus can lead to meningitis or encephalitis. Mastoidectomy is performed if antibiotic therapy has failed. Cholesteatoma is a benign cyst or tumor that fills the mastoid cavity and erodes the mastoid air cells. This process can also damage the ossicles. So again, a cholesteatoma is a mass composed of cholesterol and epithelial cells that is either congenital or occurs as a complication of chronic otitis media, and it's located in the middle ear. Okay. All right, in the third column, earache, headache, purulent discharge from the ear, hearing loss, dizziness, and weakness of the facial muscles due to damage of the 7th cranial nerve are evidence of cholesteatoma. So on 640, in that figure 17.7, I have underlined 7th cranial nerve, just to make sure you know that this is the nerve that we're working around and it's being affected. Okay, and number 6 under the surgical procedure, again, there's your rosin needle and pick. Okay, there's the rosin again. So that takes us to 642, the stapedectomy. So otosclerosis, and again, otosclerosis, so sclerosis means it's that suffix relating to hardening of a structure or tissue due to a pathological occurrence. So otosclerosis occurs when there is a bony overgrowth of the stapes. This progressive disease is hereditary, affecting women more than men. Eventually, the footplate of the stapes becomes fixed to the oval window, preventing the normal sound vibrations from entering the inner ear. Okay, and that will take us to 645, the cochlear implant. So the inner ear, or labyrinth, consists of two main sections, bony and membranous labyrinth, located in the temporal bone. Perilymph fluid fills the spaces of the bony labyrinth. The three compartments of the bony labyrinth are the vestibule, semicircular canals, and cochlea. The vestibule separates the cochlea from the semicircular canals. Three semicircular canals make up the lateral portion of the bony labyrinth. The membranous labyrinth extends inside each canal, referred to as the semicircular ducts. The base of each canal has a small swelling called the ampulla. Each ampulla contains ampullary crests that have sensitive hair cells called cristae. Dynamic equilibrium is controlled by the cristae. And dynamic equilibrium is the individual's ability to adjust to displacements of the body's center of gravity. So that's why if you have issues with the inside of your ear, your balance is going to be off. These are the people that have bad vertigo. Okay, the principal organs of equilibrium are the vestibule and the semicircular ducts. The vestibular branch of the vestibulocochlear nerve, which is cranial nerve 8, carries the information related to equilibrium to the cerebral cortex. The organs of Corti are contained within the cochlea, a coiled portion of the bony labyrinth. The organs of Corti consist of a series of hair cells that directly contact the fibers of the cochlear nerve, which is also a branch of the vestibulocochlear nerve that conducts sound impulses to the auditory cortex of the temporal lobe of the brain. Sensorineural deafness, also called nerve deafness, involves the cochlea and acoustic nerve. It's a lot of information. All right, on 647, let's start on the nasal procedures. So the nose is a facial feature that serves as the organ for the sense of smell and as the upper portion of the respiratory system. Under radiography, it has in red epistaxis. I need you to know that epistaxis is a nosebleed. Under routine instruments, it's talking about instrumentation for rhinoplasty, and that's often considered plastic surgery. But again, rhino is a combining form that means nose, so you'll have to have a lot of nasal instruments, as well as some plastic surgery instruments also. On page 648, you can see the basic nasal set. 1, 2, 3, 4. The fifth one on the left, there's the Ballinger swivel knife. And then halfway down, there's the Knight nasal scissors. So anytime you see Knight or Takahashi, I need you to think of nasal under ENT. Bottom left is the Joseph skin hook. Upper right is the Joseph double hook. So lots of Josephs here. About 2/3 of the way down, there's the Takahashi nasal cutting forceps, and then the Jansen Middleton septum forceps. So you have 6 on here that I want you to know. Now on the next page, letter J, those are the Knight nasal scissors. See how they're angled? So those are pretty easy to spot. Okay. Let's see, on 650, letters U and V, those are Joseph single hook and Joseph double hook retractors. They're sharp retractors. You might want to write that they're sharp retractors. I know it's a no-brainer, but just to reiterate, it is a no, they are sharp. On 651, double E, that's the Jansen Middleton septum forceps. And you need to write something next to letter E, or double E, excuse me. That these forceps, this septum forceps, this is a double action cupped forceps. So it's like a double action ronger. You can see two things are happening when you squeeze them, but at the tip you can see how they're cups like a kerosene. I'm sorry, like a pituitary? Pituitary, excuse me. So it's a double-actioned cupped forceps. Letter Y is the nasal speculum, the Vienna nasal speculum. Those are very common. And the double A, that's the caudal speculum. The caudal spectum, excuse me, septum speculum. Try to say that 2 times fast. So there's Y, double A, and double E that I need you to know here. Okay, so in the bullets on the left-hand side, 4 towards the bottom, it says topical anesthetic, which is cocaine 4%. This is preferred before incision. You may want to write that. That the topical anesthetic is preferred before incision. You want to put that on before any kind of incision. Okay, so they're going to put it inside the nose, but it's still topical because you have not made incision. It's going to go on that mucous membrane up there. All right, second column, second sentence, protective eyewear should be available for the patient. So sometimes they're awake, sometimes they're not, but this bright, bright lights are going to be shining in their eyes. And if they open their eyes, something might fling into their eyes. So either a towel over their eyes or some really dark goggles or something can go over their face, over their eyes. Okay, on page 652, letter B, there's that Takahashi cutting forceps, and notice that there's a pistol grip. It's like a pituitary. It looks just like a pituitary. In fact, at the top there's the cupped tip, and then there's the pistol grip. So if there's a question on the exam that asks what pistol gripped instrument is used in a basic nasal set, you're going to say the Takahashi cutting forceps. Okay, so at the bottom of 652, it's talking about the submucous resection, or SMR. So the submucous resection is a surgical procedure to restore normal breathing. It involves incising the mucous membrane lining of the nasal cavity, lifting the underlying perichondrium, removing underlying mucous membrane structures, and placing the mucous membrane back into position, also called a septoplasty. Okay, but it says here the SMR indicates that the mucous membrane lining the nasal cavity will be incised and the underlying perichondrium or periosteum lifted. And then on 653, we'll talk about the SMR and the septoplasty. Okay, septoplasty is most often performed to straighten a deviated nasal septum, and you can see what that looks like right next to it. And at the bottom it says septoplasty is often done in conjunction with rhinoplasty. So our first procedure is the SMR septoplasty. The nasal cavity is divided into 2 chambers by the nasal septum. Anteriorly, the septum is cartilaginous. Posteriorly, the septum has bony attachments to the ethmoid and vomer bones. The septal cartilage is also known as a quadrilateral cartilage. The nasal septum is typically straight at birth. During aging, the septum tends to deviate to one side or the other. The septum may also become deviated due to trauma. So under the equipment, make sure that you know that you're going to be using a basic nasal set. You may want to write that you're using a basic nasal set. All right, under the surgical procedure on 654, number 2, the procedural consideration, there you can see you're using the caudal clamp, and you know what that looks like now. And then number 4, the procedural consideration, it says the surg tech may be asked to tap the chisel held by the surgeon with the mallet. Bayonet or Takahashi forceps will be needed to extract tissue remnants. So you will be asked to tap the chisel on septal cases. Okay, and you may want to write that. I have that written there, that you may be asked to tap that chisel with the mallet on septal cases. And then you need to make sure you know that pearl of wisdom at the bottom. If any cocaine is left at the end of the procedure, be sure that it is irretrievably discarded. For legal reasons and accountability, the surge tech should ask the circulator to observe the discard process. Again, normally it takes both of you to witness this, but you would add some fluid to that topical cocaine if it's still in powder form, and you pour it over your sharps in the sharps container. Okay, turbinectomy. Each nasal cavity has a series of 4 bony projections called turbinates, also called conchae. The turbinates are osseous ridges on the lateral walls of the cavity. Their names indicate location, so they're supreme, superior, middle, and inferior. The orifice of each eustachian tube enters the nasal cavity posterior to the turbinates. Hypertrophy turbinates may occur as a result of chronic rhinitis. So these are people with bad allergies. Okay, under the surgical procedure, the following provides brief descriptions in paragraph form as a turbinectomy is similar to a septoplasty. So here are the 3 different kinds of turbinectomies. There's inferior turbinectomy, microdebridor turbinectomy, and the laser turbinectomy. That's all I need you to know. And that takes us to the polypectomy. The nasal cavity is the most interior chamber of the nose and is lined with mucous membrane. Its 2 outside openings or nostrils are referred to as the external nares. The internal nares are the openings from the nasal cavity into the pharynx. The hard and soft palates, respectively, form the anterior and posterior floor of the nasal cavity. Polyps are growths that originate from mucous membrane. It's often precancerous growths, I'll tell you that. Often the polyps arise from the walls of the sinuses or the ostia and protrude into the nasal passageway. And I have a big arrow pointing to this first sub-bullet. Most often, nasal polyps develop in patients suffering from allergic rhinitis. The recurrent inflammatory process eventually causes a small swelling that enlarges with each subsequent episode. The polyp is connected to the mucous membrane by a pedicle. Polyps can be multiple, and in some cases the size and number may cause complete obstruction of the nose. The sense of olfaction, and again olfaction is the sense of smell, that's often impaired. So again, these are people with bad chronic allergies. They may be getting allergy shots, but they always have inflammation. All right, that takes us to 658, the choanal atresia repair. Choanal atresia is a congenital, and congenital again means present at birth. That is a congenital defect caused by the failure of the nasopharyngeal septum to rupture during the embryonic development. The result is the bony or membranous occlusion of the passageway between the nose and the pharynx. So they're unable to breathe through their nose. That rupture did not happen. All right, under the pre-op tests, the third one, when an 8 French catheter cannot be inserted, choanal atresia is suspected due to blockage of the nasal passage. So that is how we know if we cannot pass that catheter down. And that takes us to the functional endoscopic sinus surgery, or FESS. A series of ducts called ostia lead to the paranasal sinuses, which are air cavities in the bone surrounding the nasal cavity. Middle column, there are 4 pairs of paranasal sinuses. Each is named by location according to the bone that encloses it. There's frontal, ethmoid, sphenoid, and maxillary. Frontal sinuses are located within the frontal bone behind the eyebrows and may be one cavity or divided. And so you can see this on 660. On the bottom on B, that anterior view, I circled where the ethmoids are. And I wrote, located on either side of the bridge of the nose. Okay, so the ethmoid ducts are located on either side of the bridge of the nose. All right, continuing on to 661, ethmoid sinuses numbering 10 to 15 are located between the eyes and have a honeycomb appearance. Sphenoid sinuses are located directly behind the nose at the center of the skull and may be one cavity or divided. Maxillary sinuses are located below the eyes and lateral to the nasal cavity. FES is performed as a diagnostic procedure and or used to treat a variety of sinus disorders, anatomical defects, and inflammatory conditions such as chronic sinusitis. The goal of FES is to re-establish normal breathing and the ability of mucus to be cleared from the sinuses. So under the equipment in the second and third column, look, there's the 4 or 5 millimeter sinuscopes, 0, 30, 70, 90, and 120 degree lenses, and a navigational system. You're going up into the sinuses, so you need a navigational system, and very small scopes. You can see what the scope looks like on 662. All right, so on 663, the intranasal antrostomy. Antrostomy is performed to treat sinusitis or remove recurrent polyps that originate within the maxillary sinus. Intranasal antrostomy is an opening into the maxillary sinus through the nasoantral wall of the maxilla just below the inferior turbinate. And so the first, the procedure here is the Caldwell-Luke. And so under the anatomy, it says the Caldwell-Luke procedure is a more radical type of antrostomy and is performed when intranasal antrostomy alone does not provide adequate visualization. The purpose of the procedure is to remove diseased portions of the antral wall, evacuate sinus contents, and establish drainage through the nose. And you can see the incision that's being used on 665, that gingivobuccal incision. So we're going through the mouth, so it's going to be kind of just clean, but this is for either cancer of the antral wall or if there's a lot of fluid buildup there. Okay, so that takes us to 666, the oral cavity and throat procedures. So in the first line, I have underlined oral cavity, and then 3 lines down, it says the pharynx, larynx, trachea, and esophagus all contribute to this complex anatomical region. So pharynx, larynx, trachea, and esophagus all make up the oral cavity, and that's why I have all those underlined strategically. Under video stroboscopy, it says video stroboscopy is used for precise analysis of endolaryngeal tissue during speech. The strobe equipment is introduced into the larynx via a flexible laryngoscope. And laryngoscope, that laryngo means it's a combining form, just that means larynx. Polysomnography. Polysomnography is an examination used to diagnose sleep apnea and determine its severity. So polysomnography, again, is a diagnostic test during which physiological variables are measured and recorded during sleep. It's often administered to individuals who suffer from some type of sleep disorder. And then apnea is that cessation of breathing. So these are people that stop breathing or have intermittent breathing while they're sleeping. Okay, on page 668, I need you to look at letter B. There's the Davis mouth gag with blades. And this is what I was trying to find out what it was during, I think, some plastic surgery. Yes, but that's what it is, the Davis mouth gag and blades. That's what attaches to the Mayo stand. You can see at the bottom of that left portion, that's what that hooks onto the Mayo stand. Letter C is the wider tongue depressor, very common. And then E is the Fisher tonsil knife. Make sure that you know all 3 of those. Okay, second column on 669, the operating microscope is a critical part of laryngeal surgery. Next paragraph, laser surgery is becoming more common in procedures involving the larynx and oropharynx. Okay, on 670, it's talking about bronchoscopes in the first column. It says bronchoscopes are also available in flexible and rigid styles and come in a variety of sizes for use in infant, pediatric, and adult patients. A rigid bronchoscope can be differentiated from the rigid esophagoscope because the distal portion is relatively straight and it houses the ventilation holes. Flexible bronchoscopes are smaller in diameter and are longer than laryngoscopes. And so what I put next to this paragraph is B for bronchoscope equals longer and distal end is straight. So when comparing to the esophagoscope in the next paragraph, it says the esophagoscope, as with the other styles of endoscopes, may be either flexible or rigid. Because the esophagus is a collapsible structure, the rigid esophagoscope is flared at the distal end for better visibility. So again, B for bronchoscope is longer and the distal end is straight. The esophagoscope, the end is flared. Okay. Okay. Yes. Okay, under practical considerations, the third line says, however, for the majority of procedures, the patient will be supine with the arms tucked at the side. A scapular roll towel will be used to slightly hyperextend the neck to provide better exposure and visualization of the surgical site. We talked about this when we talked about bronchoscopes down into the lungs. But what I want you to also write next to here is that scapular roll. It could also be used for a thyroidectomy. So make sure that you know that the scapular roll mentioned here could be also used for a thyroidectomy procedure. So the first procedure is the tonsillectomy and adenoidectomy. The pharynx is a tubular structure that serves the respiratory tract from receiving air from the mouth and nose and the digestive system as a passageway for food and liquids. The pharynx begins at the internal nares and terminates posterior to the larynx at the level of the esophagus. Third one, it is divided into three regions, the nasopharynx, oropharynx, and laryngopharynx. The nasopharynx is the most superior portion of the pharynx, located posteriorly to the nasal cavity. Beginning at the posterior nares, the nasopharynx extends inferiorly to the uvula. The eustachian tubes enter the nasopharynx and it houses the pharyngeal tonsils. The pharyngeal tonsils are a single mass of lymphatic tissue embedded in the mucous membrane of the posterior wall of the nasopharynx. When the pharyngeal tonsils are enlarged, they are referred to as the adenoids. The tonsils provide protection against pathogens entering the nose. The lymphatic tissue of the tonsils usually begins to shrink in size after about age 7. The oropharynx is the middle portion of the pharynx located posterior to the oral cavity, and it houses the palatine and lingual tonsils. The oropharynx begins at the uvula, communicates superiorly with the nasopharynx, and extends to the level of the hyoid bone. Next, the palatine or faucial tonsils are the two oval masses of lymphoid tissue commonly called the tonsils. The palatine tonsils are located at each edge of the fauces with the folds of two bands of tissue that descend from the soft palate to the base of the tongue called the tonsillar pillars. Okay. Next page, continuing. The tonsils produce lymphocytes. Each tonsil contains 10 to 20 crypts that help trap bacteria. All right, tonsillitis may affect the pharyngeal, palatine, and lingual tonsils. It usually refers to the palatine tonsils. Tonsillitis of the palatine tonsils may be acute or chronic. Most often it is caused by streptococcal organism. Okay, so it talked about those 10 to 20 crypts that help trap bacteria. These are called tonsilliths, and if you still have your tonsils, or back in the day before you got your tonsils taken out, if you ever coughed up a white or yellow ball from the back of your throat and it smelled really bad, that's what a tonsillith is. And if you have recurrent tonsillitis, if you open your mouth really wide and say ah, where your tonsils will start to show, you can see those white crypts, those crypts that are filled with these white, nasty, stinky balls. And so sometimes you can dislodge them yourself using a finger or a toothbrush to alleviate that halitosis, which is bad breath, or you can get on antibiotics and they will go away on their own. So on 673 in the middle column, adenoiditis is inflammation of the pharyngeal tonsils. This is usually bacterial, although it can be viral or due to allergies. Recurrent adenoiditis can lead to hypertrophy, and hypertrophy is enlargement or overgrowth of a structure due to an increase in the size of its cells. The hypertrophic tissue can cause snoring due to nasal obstruction or hearing impairment due to eustachian tube blockage. The palatine tonsils and adenoids are excised during a tonsillectomy and adenoidectomy, also known as a TNA procedure, which is the surgical removal of the tonsils and adenoids. Okay, very common procedure, very. So the pearl of wisdom that accompanies this on 676, you need to know this. It says, if it is necessary to distinguish the right from the left, is talking about specimens with the tonsils, the surge tech should make the necessary adjustments. So basically, what I want you to know is that the best answer here is if a question asks, do you send the tonsil specimens together or separate? You're going to say separated. So the left tonsil in one, the right tonsil in another specimen cup. That's the best answer. Okay, next is the parotidectomy. Saliva is secreted by 3 pairs of salivary glands that are situated outside the oral cavity: parotid, submandibular, and sublingual glands. The saliva they secrete is transported to the cavity via ducts. The parotid gland is the largest of the 3 glands located on the lateral sides of the face anterior to the external ear. Next column. A significant concern when performing surgery on the parotid gland is the course of the facial nerve because it travels through the gland, dividing the superficial portion from the deeper portion. A parotidectomy is the excision of a portion of or all of the parotid gland. And then last column, the gland may also have to be partially or fully excised due to a benign or malignant mass. Most tumors occur in the superficial lobe. So under the equipment in the second column, make sure you know that they're going to be using a nerve stimulator. And you can see this in the surgical procedure number 6 and number 7. So number 6, it says the facial nerve is gently retracted, and number 7, there's the nerve branches. I have both these underlined, and that's indicating that this is when they're going to use the nerve stimulator, is in number 6 and number 7. Okay. The uvulopalato-pharyngoplasty, or UPPP. The roof of the mouth consists of 2 segments that are collectively referred to as the palate. The anterior segment is referred to as the hard palate and is supported by extensions of the maxillary and palatine bones. The soft palate is posterior and consists of connective tissue and muscle. The soft palate terminates with a projection of lymphoid tissue called the uvula. During swallowing, the nasopharynx is protected by the soft palate, which moves upward to seal off the nasopharynx, directing food and liquids downward. UPPP, which is the surgical procedure to treat inretractable snoring and obstructive sleep apnea. It involves removal of the redundant tissue of the fauces, tonsils, and a portion of the soft palate, including the uvula. So again, UPPP is performed to treat patients who suffer from sleep apnea. Sleep apnea patients suffer numerous brief interruptions in respiration during sleep, leaving the patient feeling sleepy during the day. All age groups and genders suffer from sleep apnea, but it is more common in males. Sleep apnea patients often have a family history of the disorder, are overweight, snore, have high blood pressure, and may have physical abnormality of the upper airway. Drug and alcohol use increases the frequency and duration of episodes. Sleep apnea is a potentially life-threatening disorder that has been linked to some serious complications, including dysrhythmias, high blood pressure, heart attack, and stroke. So if you think about it, sleep apnea is common in males because they are more barrel-chested than females. They have wider chest and a larger diaphragm, so that's why it is more common in males. Okay, so you can see what's going on 680. Before and after we're removing those entire structures in the back of the mouth. So that takes us to the laryngectomy. The larynx is located between the pharynx and trachea. 9 laryngeal cartilages and hyoid bone forms its rigid framework. Muscles and ligaments connect the cartilages to one another. The larynx has ligamentous attachments to the hyoid bone. There are 3 pairs of cartilages: arytenoid, corniculate, and cuneiform. 3 individual cartilages, thyroid, cricoids, and epiglottis. All the cartilages except the epiglottis are formed of hyaline cartilage. The epiglottis is elastic cartilage. The largest and most superior of the single cartilages is the thyroid cartilage. It consists of a pair of shield-like plates fused in the front, projecting forward to form what is commonly known as the Adam's apple. The cricoid cartilage is the only cartilage in the upper respiratory tract to form a complete circle and is located at the base of the larynx. And then further down, the arytenoid cartilages are the largest of the paired laryngeal cartilages. Okay, next page on 682, middle column. The superior opening into the larynx is the glottis, and the glottis is the small opening between the true vocal cords. 2 pairs of ligaments extend to the posterior surface of the thyroid cartilage from the arytenoid cartilages. The uppermost are called the false vocal cords. The lower pair is the true vocal cords. So at the bottom in the middle column, it says persons who smoke are a greater risk for developing laryngeal neoplasms. Okay. On 683, the middle column at the bottom, a laryngectomy may be performed as diversion for total separation of the digestive and respiratory tract or due to chondroradionecrosis. So chondroradionecrosis is one of the most serious complications of radiation therapy. It may progress or become fatal despite aggressive treatment measures. So this is due to cancer of the laryngeal structure, a condition that occurs due to radiation treatments. There you go. Further down, total laryngectomy is performed when cancer is in advanced stages. It involves removal of the larynx, strap muscles, hyoid bone, and pre-epiglottic space. If the lymph nodes in the neck are involved, a radical neck dissection will also be performed. Okay, and you can see a picture of that on 685, the laryngectomy. And that will take us to the big case, the radical neck dissection with mandibulectomy. All right, procedures performed to treat metastatic squamous cell carcinoma, also performed in conjunction with mandibulectomy for metastatic cancer of the mouth and jaw. The tongue is a thick and muscular organ divided into 2 main parts, the oral tongue and the base of the tongue. The oral tongue is the first 2/3 of the tongue and the part of the tongue seen when viewing into the mouth. The base of the tongue is part of the oropharynx. A glossectomy may be an additional procedure if the metastatic carcinoma has been confirmed in the tongue. A partial glossectomy is removal of any part of the tongue. A total glossectomy is removal of the entire tongue, including the base of the tongue. So what I really want you to know on the equipment is that there are going to be 2 teams. There's Team A and Team B. We're going to talk more about these teams here momentarily. So on 687, under the practical considerations, radical neck dissection is usually performed unilaterally. The cervical lymph nodes, jugular vein, and SCM are removed. Okay. For both psychological and physiological reasons, the ensuing defect caused by the extensive resection requires immediate reconstruction with the use of a composite graft. Several body structures make viable composite grafts for mandibular reconstruction, including the fibula and its adjoining vessels. And then it says 2 teams working concurrently are often used. Okay, so if you see in the third column it says Team A is non-sterile, Team B is sterile. Okay, so there's the non-sterile people, the neck, and then B, Team B, the sterile, which is the extremity people. Okay, getting the graft. All right, that takes us to 691, the temporomandibular joint arthroscopy. You need to write next to this that this is done on the lateral jaw. Temporomandibular joint arthroscopy is performed on the lateral jaw. The largest and strongest facial bone is the mandible. The mandible articulates with the glenoid fossa of each temporal bone to form a synovial joint called the temporomandibular joint, or TMJ. The TMJ contains the condylar process of the mandible and two parts of the temporal bone, the mandibular fossa and the articular tubercle. TMJ arthroscopy is usually performed for diagnostic purposes to confirm it. To confirm it, temporal mandibular disorder or TMD exists. TMD is divided into two classifications: muscle-related TMD called myogenous TMD, caused by chronic jaw clenching, and joint-related TMD called arthrogenous TMD, caused by the malocclusion of the teeth. TMD is second to toothaches if the cause in the cause of facial pain. Okay, so we are alleviating that TMJ. And the last one on 694 is the tracheotomy. So the trachea is located anterior to the esophagus. The upper half of the trachea is located in the midline of the neck. As it descends, it enters the superior mediastinum. The trachea joins the cricoid cartilage of the larynx to the main stem or primary bronchi leading to each lung. There are 15 to 20 C-shaped pieces of hyaline cartilage supporting the anterior and lateral tracheal walls. These cartilages keep the trachea from collapsing due to any pressure changes. The posterior wall of the trachea is closed with smooth muscle and connective tissue. This allows for expansion of the esophagus during swallowing. The most inferior tracheal cartilage is called the carina, and the carina is the inferior tracheal cartilage that bifurcates into the two primary bronchi. Yep, which I just said. Yep. Okay. And here I will demonstrate cricoid pressure. We talked about this earlier, but I will demonstrate cricoid pressure again. On 695, under the practical considerations, second bullet, it is performed to facilitate breathing and to protect damage to other structures. The terms tracheostomy and tracheotomy are often used interchangeably. Tracheostomy is the creation of a tracheal stoma, usually permanent. The mucous membrane of the trachea is sutured to the skin. Tracheotomy is the creation of an opening in the trachea, usually temporary, for placement of a tracheotomy tube. Have the tracheotomy tube on the back table before incision is made to ensure patency of the balloon. Yes. And that wraps up the last chapter of the year, chapter 17.